Good morning, everyone. Good morning. Good morning to our esteemed guests that are speaking on today's panel, and good morning to all of our participants that have taken the time to join in with us today. It's Black History Month, and in partnership with the FDA and CISCRP and Peer Plus Education and Training Advocates, today we are going to discuss and have a straight talk conversation about cancer, COVID, and long haulers. And I know we've been hearing so much about this, so we just felt it was our obligation to address it. Two things I need for you to know right away. This program is being recorded, and we would like to know if you could check off the box to let us know how you heard about today's event. That's very important for us, for our data, and for what we need to continue to follow through. So it's a little short survey. We know that some of you may have to leave before the event is over. So if you could please take a moment and just check off the box of how you heard about it through email, Facebook, social media, through a friend, or whichever way you receive the information. Thank you. And we will get started right now. I would like to welcome everyone again, our partners with CISCRP and our partners with the FDA. We have a tremendous group of people that's going to be on this call today. All of these people with all of this experience and information that needs to be shared as we're all dealing with this pandemic. A pandemic that we don't know when it's going to end. But we're just asking everybody to continue to practice safety, and we're all going to do the best that we can to get it through. But today we're just going to talk, and please don't feel inhibited by anything that you hear. We want you to please use the chat box. We have none other than Dr. Kareem Watson from the University of Illinois that is monitoring that chat box to answer your questions. So we're going to do our best to try to answer the questions as we're going through. Each panelist will present, and then they will give a little bit more toward the end. We want to go on and get started. I would like to introduce to you all from the FDA, we have Rhea Blakey, we have Dr. Matthew, and we have Dr. Singh. This is a tremendous group that is coming to us that's going to start off the conversation. But Rhea, I would like to put it back into your hands.
All right. Well, thank you, Phyllis Rogers, well known in the Chicago community and across the nation as a very strong advocate for all things that have to do with wellness. We really appreciate everything that you've done with Peer Plus and the training advocates, and we look forward to this conversation. I'm thrilled that my colleagues, who really are the subject matter experts, are also joining this particular call because there is great strength in the resources that they bring. So I won't take a whole lot of time, but very quickly, I do want you to know that joining us on this call today is Dr. Harpreet Singh, along with being a phenomenal friend. She's also the Associate Director of Oncology in Older Adults and Special Populations at the FDA Oncology Center of Excellence. And she is also a specialist when it comes to lung cancer issues. Alongside her is Dr. Luxon Matthew, who is also with the Food and Drug Administration in the Oncology Division 2, I believe, which is head and neck cancers. He's a thoracic medical oncologist, and so they're both well-versed in the information that they're going to be presenting to you today. We also have on this panel, not to be lost, a great resource in Dr. Deborah Burnett, who's the section chief of general medicine and a professor of medicine at the University of Chicago, and who operates a COVID clinic. She is probably going to be a great resource for those of you who are based in the Chicago area, but all three of them are exquisite members of the medical community that's addressing this really burgeoning issue. I do want to start with the thought that it's never lost on any of us that the most important person in any conversation is the patient. It is the people at the community level who are, experiencing symptoms, issues, concerns, etc. And we are going to try to address those in this straight talk conversation. So thank you, Phyllis Rogers, for creating this opportunity for us to have this moment together. Again, patient-centric, want to talk with people, consumers, actual people in the community. So we look forward to hearing your questions and answers. And of course, as mentioned, the answers will be provided by the panel, hopefully. But doesn't mean that patients don't have answers too. Dr. Kareem Watson, we want to thank you in particular. He is an Associate Director of Community Outreach and Engagement at the University of Illinois Cancer Center. Many of you probably know him very well. He's very active in the Community Health Services Division of UIC School of Public Health. So without further ado, we like to start with patients. And for this particular session, our patient person is Phyllis Rogers herself, who is a cancer survivor, who is a COVID survivor, and who herself has been experiencing long hauler syndrome. So if you wouldn't mind, Ms. Rogers, share with us, and we appreciate your personal information because you don't have to share it, but it's important for the community. Give us a sense of what you were experiencing when you were first diagnosed with COVID, extend to family, and what long haulers means to you.
Well, thank you, Rhea. And again, thank you all for joining Peer Plus for our annual Black History event. Back in November of 2020, my husband became very ill. We took him to the doctor 2 times, and no one was able to let us know what was going on. We had no answers. And then finally, one Monday morning, he was struggling with breathing and was spiking the temperature. We phoned the paramedics, and they took him directly to the University of Chicago, where they diagnosed him with COVID and started him immediately on medication. I wasn't feeling well during that time. My son was already not feeling well, and my daughter also. So my son was already tested and waiting for his results. I went that exact same day that my husband was admitted into the hospital and received a diagnosis in a couple of days. Because of my education around infectious diseases, I already knew that I had every symptom, that they were talking about. I had the severe headache, the joint pain. I wasn't short of breath, but my smell was kind of going in and out, and it was just a pain that I just could not explain what was going on. So that was for 4 people in my family through November. By Thanksgiving, we were all much better, but then we really were not much better because I don't think we were really talking to each other about what else we were feeling. And so for me, I began to feel the fatigue. And whereas I still feel the fatigue now, I mean, during the day, there's just times that I just I can barely move. Thank God I have not had any of the taste and smell, but both of my children have been dealing with the taste and smell. And with my husband, some of his, they said, was going back to memory because he has no recollection of being taken from the house by the paramedics and being taken to the hospital. So he's had some therapy around that, and he's going to continue to follow up with that. But for me, myself, mine is all around the fatigue. And not only am I dealing with that, I'm also a 19 lymph node colon cancer survivor. So I'm dealing with that also. I haven't received my vaccine as of yet because I've had some other issues going on, but I am going to be doing that, really soon. And so when we started hearing about long haulers, and I started doing my research, I said, that's me. That's my family, what's going on. And then I began to see more and more about it. And, when I brought it to your attention, I said, this is something that we must address because more and more people are probably going through it. But, we self-diagnose, especially as women, because we're so busy. We take a pain pill for this and another pain pill for that, and we continue to move. But when it's not giving you the result that you're used to, we know that something else is wrong. I met with my provider a couple of weeks ago, and so they're doing some things to monitor me, to see how things are kind of bouncing up and down. But as a community person, I just felt it's our due diligence to get this information out so people can have questions answered. And that's what we're hoping for today. I know no one has all of the answers, But as long as we can have the conversation, there's an opportunity for people to get better and to be able to share this, because I know there are friends of mine that are on this call today that have also been through COVID, and they're dealing with some of the long hauler syndrome pieces as I and my family right now. So that's where I am with it. And thank you so much, Dr. Burnett, for being on here to share your thoughts around this. We have to depend on people like Dr. Burnett and others to tell us, you know, what it is we should be looking for, and maybe what's available to us down the line, you know, within the community. But that's my story. I'm a fighter, as you can see it. I have all three. I've had COVID, I have had cancer, and now I'm dealing with long haulers. But we're not going to throw in the towel. We're going to give it our best shot. Thank you for that opportunity.
No, we really appreciate you, Phyllis. You know that. But a nice segue into Dr. Burnett. Talk to us about your experience thus far throughout this pandemic.
Sure. Thank you, Ria, and thank you, Phyllis, for sharing that story, because it's very helpful and it illustrates a lot of the points I want to talk about. Just to recap, I see adults and kids. I'm a professor of medicine and pediatrics, and I oversee the adult primary care activities at University of Chicago. I study health disparities, especially around obesity and diabetes. And then, of course, this year I've really focused a lot on COVID, including post-COVID and chronic long hauler symptoms. I'm also a community member. I lived on the south side of Chicago for many years. I currently live in the south suburbs. I'm a church member. In fact, my husband is the pastor of Faith Lutheran Church in Homewood, Illinois. So that's where I'm coming from. And I have been seeing many patients and, talking with colleagues, both at University of Chicago and around the country, who are now seeing and caring for long COVID or COVID long hauler syndrome. So I want to talk a little bit about what that is and what to expect and what we can do for it. So COVID, the acute illness, as you know, generally lasts a couple of weeks or so. It has the familiar symptoms of cold symptoms, cough, shortness of breath, sometimes much worse than that than others. Some people, of course, need to be hospitalized. Once that acute phase is over, usually less than 4 weeks, some people do, many people do experience some ongoing symptoms. Now, when does it become so-called long haul COVID? The way we've been studying this and talking about it in the medical community is the acute phase is the first 4 weeks or so, even though most people get better acutely within a couple of weeks. The period from 4 weeks up to 12 weeks or 3 months, that's considered ongoing symptoms of COVID. People who have symptoms beyond 12 weeks or more than 3 months later, that's when we consider it post-COVID or chronic or long haul COVID. So that's pretty much what we want to focus on now. I want to say, before I even dive in further, the vast majority of people who do have these symptoms ongoing 12 weeks and longer, it's difficult, it's challenging, but the vast majority of them do improve over time and the symptoms get better. For any given individual, we can't predict exactly when and how that's going to happen. But as we are starting to learn about this from people around the country and around the world, it does get better over time. Now, what do we see and what do we do for it in the meantime? The symptoms experienced by people in this long haul phase of COVID often include the following things: fatigue, just like Ms. Rogers was telling us about, just ongoing fatigue, can't do the stuff you used to do. Some patients have shortness of breath, cough, sometimes chest pain, sometimes palpitation, your heart beats and races fast, especially if you get up and walk or try to exercise. Some people have joint pains, muscle pains. Brain fog is a big one, and that's the language that patients use. I can't concentrate, I can't do my schoolwork, I can't work, I can't do my email. So inability to concentrate. And then some people also have persisting problems with smell and taste, although those usually do get better over time. How many people get post-COVID or long haul COVID? The reports vary a lot. And it's also, you have to sort through the literature, both the scientific and the popular reports, because often you'll see a report that says, in this study, 1/3 of patients still had symptoms at 6 weeks. So that a lot of the, they're not all broken down into those categories I told you before. But as we get out to that 3-month phase, when we would really consider it the long haul phase, there are fewer people, but yes, some people still have symptoms. The people who are more likely to have ongoing persistent symptoms in general include people who are older, people who have more underlying conditions, chronic illnesses, people who have been hospitalized with COVID because they had a more severe case of COVID. Some people have been hospitalized more than once. It's also interesting, this is different from acute COVID. We see the long haul symptoms more often in women than we do in men, which is different, as I said, from acute COVID. For acute COVID, the people who are most likely to get severe illness, be hospitalized, and be at higher risk for death are actually men. We don't really understand why that is true, but the reverse is true for the long haul phase. It's anybody can have it, but it's more commonly seen in women. We are also starting to recognize it in kids, young adults, so people in their 20s who had a very mild case of COVID, but then have some ongoing persistent problems, which is quite distressing because that person is 24 years old and always was able to do whatever she wanted to do. And now something's getting in the way. So we see it even in people who are younger and healthy, and also including in kids. I just saw a report from Rome on a couple hundred children and people up to age 18, some of whom are having these same kind of ongoing symptoms. So why does this happen? We don't understand a lot about that yet. There are some other viruses that can also trigger long symptoms like this. Most viruses do not. Like if you have a cold, you get better, you don't have ongoing symptoms. But the couple of them that are related actually to COVID do cause similar syndromes. The SARS virus and the MERS virus, you may have heard about those. Those are also coronaviruses that had much smaller epidemics, a few years back, but some of those patients also suffered longer term symptoms. So we are still exploring, why certain people get it, why it happens, and then of course what we can do to treat it. What we do in the meantime, both patients and physicians, here's some things to watch out for. First of all, I would say if you are having ongoing symptoms, the first stop should usually be your own doc. If you have a doc, see your own primary care physician or provider. That's a good place to start. But the things that we're going to look out for when we see you and that you should be on the lookout for are things that could be more severe. Most people who have ongoing symptoms, they are distressing, they are bothersome, but generally not life-threatening. However, the things we want to look for that could be more severe and require more urgent intervention include things with your heart, things with your lungs. And so I can tell you a little bit about those. You might have seen reports in athletes, including competitive and professional athletes, of what we call myocarditis. Myocarditis means viral infection and inflammation of your heart, the muscle itself. And that can cause the heart not to work right. It can cause pain. It can cause exercise intolerance. Competitive, serious athletes should rest for several weeks after COVID and then gradually increase their exercise. And any of us, if somebody's having these symptoms that are more pronounced, ongoing chest pain, bad shortness of breath, you get up and walk a block and you can't breathe, you got to see a doctor. Again, start with your primary care doc. You may get referred to, you may need to see a cardiologist. You may need some tests for that, which could include things like a cardiopulmonary stress test, where the physicians and technicians monitor you as you walk on a treadmill, et cetera, or sometimes an MRI of your heart or an echo, which is an ultrasound. So for more severe, chest pain or just bad, I completely get out of breath when I walk a block or something, very different from your baseline, good idea to go get checked out. Similarly, the lungs can be involved in a more serious way in the long-term, long haul syndrome. So for people who are having bad shortness of breath, ongoing cough, et cetera, they might need further lung testing. Could be pulmonary function testing, which is breathing tests like we do for people with asthma or suspected asthma. easy test to do. May need a CAT scan just to get a picture of your lungs. In not common, but in a small number of cases, there can be, ongoing damage in the lungs. So if you're coughing, short of breath, bad, and it's not getting better, then it's a good idea to get seen, and the doc will help you figure out if you need further heart or lung evaluation. The last area I want to talk about is psychiatric, mental health, well-being. There is a great increased incidence of anxiety, depression, insomnia. I talked before about the brain fog, can't concentrate. And again, we don't have a great understanding of how this happens. Is it a direct effect of the virus? Is it some ongoing inflammation or an immune function where our immune system starts acting up against our nervous system? So we are exploring, and doctors and scientists around the world are working with patients to try to understand it better. But there are some things that we can and should do in the meantime. If those symptoms are very bothersome, it's also a good idea to see a doc. Start with a primary care doc. Maybe, for any of these more severe problems, you can also look for, a post-COVID long haul clinic. And I tell you more about those in a minute, both at U of C and elsewhere. But things that we can do for this, the things I mentioned, worsened anxiety, sometimes like PTSD symptoms, sometimes like, post-traumatic stress symptoms, especially for people that were hospitalized with severe COVID. Or the brain fog. We may do some further evaluation. If you really are not thinking right, some people will undergo what we call neuropsych testing, which measures, how well you're thinking, just like the pulmonary function test measures how well you're breathing. What can we do for these things? So a combination of things. And right now I'm speaking again about things like the anxiety, depression, also moving into the realm of joint pains, fatigue, et cetera. So what do we do to help patients? Most of these things will get better, but things we can do in the meantime. Often physical therapy is helpful, and the physical therapist can help with a graded, gradually increasing exercise program. Sometimes you may want to see a doctor who's called a physiatrist, and that discipline is called physical medicine and rehab. So that's an MD who works alongside with physical therapists and really does a very thorough assessment. This is like rehab places do lists, like Shirley Ryan Rehab and other places, University of Chicago also. The physical medicine and rehab and the physical therapy can help you on a gradually increasing program to increase your exercise capacity. Sometimes cognitive therapy, counseling can help you deal with the stress of the illness itself, the stress of recovery. How does this fit into your life? It might have turned your life upside down. You can't work, you can't care for your kids. So working with a counselor or a therapist can be very helpful in terms of coping and putting those pieces back together over time. The other things that undergird all of these recovery efforts are the things your grandmother always told you. You got to sleep enough, hopefully. That means 7 or 8 hours a night at least, and give yourself every best chance to do that. Harder for people who might work at night, for instance, but good sleep, healthy nutrition, hydration, got to drink throughout the day. By good nutrition, I mean fresh fruits and vegetables, varied diet, some sources of protein, to cut back as much as possible on the junk foods and so forth. Also minimize alcohol, especially if you're having some of these cognitive and related symptoms. And then gentle increase in exercise. Again, most people will recover. Places to go, your primary care doc, also a post-COVID recovery clinic. We have one at University of Chicago. You can Google that and find it. I can tell you the phone number, which is 773-702-7826. There's also a listing on the web. It's called Survivor Corps. And Survivor Corps lists a whole lot of post-COVID recovery clinics. There are others in Chicago now. I believe Northwestern, Rush, maybe some other places also have them. So that's a good link, is the Survivor Corps. Last thing I want to say, and echo what a couple people said already, is get a vaccine. Whether or not you had COVID, it's smart and healthy to get a vaccine. It can protect even if you did have COVID. After 90 days, you're eligible for a vaccine, when it's your turn, and that will help to prevent having it again. You know, it is known that some people will get it again. We don't know how long the natural immunity lasts. So get your vaccine. It's not a live vaccine, so it can't give you COVID itself. You know, some people have some mild side effects, but on average, that vaccine is a lot better for your health and a lot less risky than waiting and getting COVID. So I'll
Dr.
stop.
Burnett, I'm sorry, but we really do want to make sure you've getting a lot of really good practical information. I do want to get our other two speakers in because we have questions coming in already in the Q&A box. And so I know that there are folks who are listening in on the call who probably have specific questions they want to jump in with. Dr. Watson, should I check with you first, or can I go ahead and have our next two speakers just give their introductory remarks?
Please have the next few speakers give their introductory remarks, and I'll then, I'm jotting the questions down and I'll forward them to our presenters.
Okay, all right, that Q&A box is on fire. All right,
it's
Dr.
on fire,
Singh.
which is great.
Dr. Singh.
Great, thanks, Ria, and thanks so much for having me. And Dr. Burnett, I thought that was such a great explanation of the stage. I'm Harpreet. I'm a medical oncologist, and I work at the FDA. Many of us at the FDA, there's about 100 oncologists, and many of us continue our medical practices within the Washington, D.C. area. I just want to hit briefly on the three topics of today: cancer, COVID, and long hauler, and what the FDA has to do with any of those. So I'll start with the cancer piece, and I really appreciate Phyllis's perspective as a patient with cancer, formerly with cancer, but I think you always hold that title, of course, as a cancer survivor. We at the FDA in the oncology group, which is where Ria, Luxon, and myself come from, it have felt very strongly since the start of the pandemic, and we could not forget about our patients with cancer, because the COVID pandemic is a once-in-a-lifetime event that will end eventually, but cancer continues to kill hundreds of thousands of patients a year, outpacing, that of the pandemic. And we wanted to make sure that drug development and progress within the area of cancer did not suffer as a result of resources being diverted to COVID within the agency. And we also heard feedback. We had several sessions, and as I mentioned, many of us remain in practice, and we had several sessions with patient advocacy groups in which patients with cancer were quite concerned that the FDA was going to slow down its approvals for cancer therapies, or not be able to continue clinical trials, which are really the key way with which new drugs come forward. So we made a very concerted effort to message and also to walk the walk and continue with really a record-setting pace of approvals, very rapid approvals, and also approvals which took into consideration keeping patients safe as they continued to get their cancer therapy. So meaning we put out guidance that said, you don't have to go visit your oncologist, the routine check-in. If it's not safe for you to do so, they can mail you your medications if they're oral, for example. Or if you're on a clinical trial and you're in Florida or Chicago and your clinical trial site is in New York, you don't have to travel to New York to go see your oncologist unless it's just really absolutely necessary. We can do a phone visit. You can do a virtual visit. And so we provided all that guidance. One thing I will say, though, is I'm not sure that was enough. And I do think that, unfortunately, we are going to see some loss of progress in the cancer space as a result of COVID due to people not getting their routine screenings, their mammograms, their pap smears, their colonoscopies. And I would urge you all to reconsider that. If you missed last year, my own parents, I've had to say, I know you skipped your mammogram, you need to go in, you need to schedule that. There's safety protocols in place, please do that. So that's the piece about FDA and cancer. We wanted to keep progress going, we've done that, but the messaging still needs to be that you need to advocate for yourselves and your cancer care we think there are plenty of ways to keep you getting your treatment safely, but that prevention piece, I think we may have lost some ground on, and I hope we can recover that. So what does FDA have to do with COVID? Well, we have a lot. We have a whole division of infectious disease doctors, and I'll let Dr. Matthew talk a little bit about the vaccine and some of that in a moment. But one thing that I've been particularly interested in a part of within cancer, COVID, and the long hauler syndrome is harnessing all the resources of the federal government and of the FDA to acquire what we call real world data. And basically that's any data that's not within the context of a clinical trial. So you go to your physician, the data then comes to us, you report that you have symptoms of long hauler syndrome, it's recorded, and we have various contracts with large companies to get that data anonymized. Of course, we don't know your name, we're not spying on you, but you know, things like age, sex, gender, we have all of that, and we're starting to kind of tabulate in the interest of public health, what is the frequency of long hauler syndrome? How does this impact patients moving forward with and without cancer? And a lot of what we're seeing is consistent with what Dr. Burnett is reporting. We see a lot of women, patients with pre-existing kind of conditions, patients who had more severe courses of COVID. And the question is, what are the next steps for the FDA to take? And I think one thing that seems to be coming through is that it seems to be underreported in the data that we receive based on what we're hearing from the community. And I believe that that's because probably there's multiple reasons, but one of them may be finding a physician who will listen to you. And I think that's just a huge piece of this, because I think that in the beginning, doctors were learning too, so you have to give us a little grace. But now I think we're in a phase of the pandemic where if you go to your physician and you tell them I've had COVID and it's months later and I'm still having symptoms and they're not like hearing you, you got to find another healthcare provider, because I think there is really a piece to this that we need to really obtain as much information as possible in order to provide more data as to what the next step should be, like these graduated exercise programs. From an FDA perspective, we're also very interested in this piece around, as an example, if you're a patient with cancer, you developed COVID, you recovered from COVID, and you continue your cancer therapy, how does that diagnosis impact how how you may respond to those cancer drugs? Because many of them work with your immune system. They're called immunotherapy. And certainly the virus has played a role in evading your immune system and being able to kind of take hold of your body. So that's something that's in the works that we're very much interested in and working on and trying to obtain the data, and we'll report that out as we get it. I'm very grateful to be here and really looking forward to the panel discussion. And so with that, I'll end my remarks and turn it over to Dr. Ria.
Oh, okay. And for me, I'm going to hand it off to Dr. That's okay, Dr. Matthew. And then if you don't mind maybe condensing any presentation you might have, sir, because I'm sure there are lots of people who have questions that they're looking to have addressed as part of the remaining less than half hour in this session. Thank you, Dr. Matthew.
Okay, so sure. Before I say anything else, first of all, I'm very grateful for this opportunity to be part of this very important conversation on cancer, COVID-19, and long hauler syndrome. So just a couple of things that, Dr. Singh, did an excellent job in summarizing FDA's role, and just echoing a couple of things. As she said, that we have taken initiatives, we have put out guidance to provide some flexibility in the midst of this pandemic. And so, if there's one thing I want to say, you remember, is that here at the FDA, we remember and we have prioritized our cancer patients in the midst of this pandemic. Cancer patients remain our priority in regards to providing optimum care options in regards from a regulatory standpoint. So just want to mention a couple things just in regards to COVID-19. And so this is a pandemic. None of us really, calculated and said that, hey, look, this is going to happen. Let's prepare for it. So it's very difficult. I think the one important thing is for us to kind of realize that we're all going through this together, and, providing a little bit of grace, a little bit of space and time is very important for us to get out of this together. In regards to the regulatory standpoint for the vaccine itself, look, this is straight talk. So let's straight talk. I know there's a lot of mistrust, and it's for a variety of reasons and in regards to the vaccine. And I'm not going to go in here and talk about all the different reasons. What I would say is this. If you have mistrust towards this vaccine, from a regulatory standpoint, the scrutiny and the level of review that was involved before these two vaccines were made available was very, very thorough in regards to the typical process. There were no cutting corners or, let's just forget about this and that. When you look at the studies themselves, the participation of minorities in each of the major two vaccines were pretty high. Some range from 20% in African-American population. Hispanics was as high as even 30-40%. So this is not, and this is global. It involved different countries. So this is not, a unilateral, study where people are left off. So I think the design of the study involved a great deal of diversity when it comes to incorporating and including, people in this study. Some of the leaders in this production of the vaccine itself, are, well diverse in regards to race. And so from a standpoint, from a regulatory position, everyone have to make that decision themselves, right? But what I would say is if there's skepticism, if there's concerns, identify specifically what those things are, and let's have a conversation. Have a conversation with your primary care. Have a conversation with your family. Don't leave it nebulous. Focus in on the specific issue that you have toward the skepticism and start digging deep. Because I think in the end, that's the way to kind of move forward in regards to, addressing some of that mistrust. So from a cancer priority, from a cancer standpoint, here at the FDA, we continue to prioritize our cancer patient. COVID-19, it wasn't something that, we would ever dream it would, or ever have in our nightmare, but it's here. And the question is, how do we respond to it? And I think if we work together, I think we will, as Dr. Singh said, we will get through this. And then the long hauler syndrome, this is something that is real. And I tip my hat off to everyone who have or continue to experience long hauler syndrome. You guys are champions. And I just want to say that we are getting more information, in the literature. There's more and more information each day. So I echo what was said before. Talk to your physician, get your experience out there so that we can get more and more information about this syndrome in order for us to better characterize it and hopefully develop interventions, that can lead forth to improvement and terminate, this very difficult situation. So I'm going to pause. As everyone said, really the important people here are you and your questions. And so I'll pause there, and I look forward to hearing your questions.
And we know Dr. Watson has been monitoring the Q&A, so sir, fire away.
All right, thank you so much. And I'm going to first put the first question out there to you, Phyllis, as a community advocate, because I like to use the term justified medical mistrust. And the reason I say justified medical mistrust, because we know a lot of communities members have, a lot of time the health system has not always been equitable to certain communities and certain populations, and even historically. And I really like what Dr. Matthews said, is that we have to move to building trust and collaborations with community members. But a lot of a lot of this is, justified based on what we know from our historical background. So Phyllis, the question I want to ask you was, what caused, as you think about your ability to engage in the healthcare system, what are some of the things that are important to you as a patient to build that trusted relationship?
Just to continue to talk and to gather information and to go to people that I trust, first of all, and then to be able to express it out in a way that they will understand what I'm saying. I don't know any of the medical terminology. I do the best that I can. but I know that better educated than I am around the disparities, it's easier for me to transfer it over to the community, being the boots on the ground. I'm looking at the amount of people that are signed on today. We don't know where they're coming from. I hope a lot of them are people that got their information through Peer Plus, but we have a large trust in the community. We've been around almost 20 years. And so we know that is some of the fear. People are constantly calling me about, are you going to take the vaccine, or what are you going to do? And I haven't shared with tons of people about the diagnosis of myself and what was happening here in my family. So I have to be open and as transparent as I can. And for that, I have to continue to reach out to people like yourself and to others on the panel to help me through it, so I can have that trust and then transfer it over to others.
Thank you so much. And that reminds me of something you said, Dr. Singh, about some people are having, like, for example, one of the questions came in and someone says, if I'm having the fog associated with COVID-19, you know, with some of that, many people are saying, Ms. Phyllis described this earlier too, you know, said I'm having some changes in my memory, some changes in my mental status. And you mentioned the importance of having a conversation with your provider about that. Can you just reiterate that quickly again for our listeners?
Yeah, I think it's so critical in every community to have a healthcare provider that you can trust and that you think will listen to you. And, you know, they may not always be your most likely, you may have several physicians or nurse practitioners. There's a healthcare team, even if it's a nurse that you think will relay, you know, I'm a physician, and guess what? I like to go to nurse practitioners for my women's health issues. That's just a personal tidbit, but I think they're more responsive sometimes. Sometimes they have more time. Sometimes it's about billing. But I think for this particular issue, because it's a little nebulous and it's new, you really, there's not even like codes for this yet, I think, Dr. Burnett, like an ICD-9 code, like how you would, that's one of the problems we're having in collecting this data. But for the more acute person who's having symptoms, I think being persistent is really important too. If you go once and you're dismissed, you go again, or you find someone else, and you're persistent in advocating for yourself, or finding someone within your family or community who can advocate on your behalf, I think is critical.
That's a great point. Dr. Burnett, I'm going to pose the next question to you, and it's going to be a twofold one. One question was about what is the recommendation for if someone has tested positive? What is the recommendation for how long after their positive COVID-19 test can they get the vaccine? There's been, you know, some talk about that time frame. Do you mind explaining that?
Sure. The recommended time to wait is 90 days. That's after a positive test or after having, you know, COVID. And the reason is we think that that's the window, you know, after 90 days, the vaccine itself will be more effective at building and boosting any immunity that you may have. You know, we think you probably get some immunity from the acute illness. We don't have a measure of how much immunity that is and how effective it is, but the recommended time frame for when to get your vaccine is 90 days after that.
And we use terms sometimes, like when you say acute illness, what do you mean by the term acute? We use these terms acute and chronic a lot. Can you just, in a quick snippet, define what we mean by acute?
Yeah, so the acute illness is, you know, COVID. It's what we normally think of having the COVID infection. You weren't sick before. Now all of a sudden you got a cough and a sore throat. It's kind of like a cold, but actually it's worse and you feel really awful. That's your acute illness. And that part usually lasts 10 days or so and gets better. Although, like we said, you can have a lot of ongoing. The other stuff, especially after 12 weeks, that's when we start referring to it as chronic.
So acute in layperson's term just means a short period of time. So this is not something that's gone ongoing and lingering. And you mentioned, before I move on to some cancer specific questions for Dr. Singh and Dr. Matthew, there was one question about immunity. If someone has been exposed to someone who's tested positive for COVID-19, or they have tested positive for COVID-19, they want to know how long are they immune, or is there even an immune response that's built from having the COVID-19 virus?
Yeah, so those are two different things. Being around someone who has COVID or being exposed is not the same as having your own positive test or diagnosis. I'm going to talk about your own positive test first. So if you have a positive test, you know, with or without symptoms, we believe that you have what we just said is acute COVID. Most of those people as we've been studying this, most of those people do develop some antibodies, and we believe they have some immunity, but we don't know how effective that is and how long that lasts. So that by itself should not change your behavior. You still should mask to protect yourself and others. Also, we don't know if people who have immunity may be able to transmit it to others, even though they're not going to get sick themselves. So for all those reasons, it's still very smart and important to continue those precautions. Now, if you're around somebody or exposed to somebody, a coworker, something else, you should be tested, but that just exposure, especially if you're negative when you get tested, that does not give you immunity.
Thank you so much for that. And then the next question is specifically to Dr. Singh and Dr. Matthew. It's about cancer patients a lot. We are so excited to have over 100 people, and Ms. Phyllis, they're not just local Chicagoans on the line. I'm seeing people saying I'm calling in from other states. One of the questions, some of the questions are linked to the fact that they may be in current treatment for their cancer. And what I heard you say earlier is that you need to have a conversation with your doctor about whether or not, if you're in current treatment, you should or should not get the vaccine. Can one of you expound on that a little bit? Dr. Singh, you want to kick us off?
Sure. I mean, I'm sorry, just one thing I wanted to go back to about the long haulers that kind of struck me as we were talking about this, and the being persistent part of it was, your symptoms may not actually be from COVID. You may have a thyroid problem that's gone undiagnosed. You may be developing something new, that's totally independent of your COVID. So of your history of COVID. So I think that's also where it comes into the persistence and advocating for yourself. But to the COVID, cancer, and vaccine question, I think it's extremely unfortunate, frankly, that patients with cancer were not enrolled in the pivotal clinical trials. That is just a straight factual piece of information. That is unfortunate. I know that there are ongoing trials as of today that are open for patients with cancer for the vaccine. If my personal patients, I would say get that vaccine in your arm as soon as you possibly can, because with the diagnosis of cancer, you are at high risk. And we do have an immense amount of data, particularly for patients with lung cancer, but also breast, prostate, etc. But we saw a lot with lung cancer, in which if you had lung cancer and you developed COVID, your outcomes were likely going to be worse than patients without that cancer diagnosis. So I do think it's an individualized conversation. The conversation with me, obviously, barring any contraindications to the vaccine, would be to go ahead. And by the way, it's a similar conversation for women who are pregnant or are planning pregnancy, for example. There's these various groups that were not included in the vaccine trials that are now being considered kind of post. And I do think it's appropriate as more data emerges to really have an individualized conversation and consider going ahead and getting the vaccine now.
So the take-home message is have that really critical conversation with your oncologist about where you stand in terms of your readiness to get the vaccine. But your overall general recommendation is that although cancer patients were not included in the Moderna and the Pfizer study, that there still is an important, or the Johnson, well, I'm talking about the ones that are FDA, that are EUA approved right now.
At the moment, yeah.
At the moment.
Yeah, I just want to add a couple of things. Yesterday, if I'm not mistaken, or the day before, some more real world data has come out in regards to, at least for Moderna, where more patients now have had the vaccine. So the studies had about like 40,000 patients in each arm. The most recent one I saw is about data on 600,000 patients. And so even with more patients, the efficacy of the vaccine remains above 90%. So, in simple terms, what it's saying is that now that we've had more people get this vaccination, that includes more people who have cancer, more people who probably wasn't included in the original studies, is showing that the drug, it remains efficacious. And so I agree, talk to your primary care doctor, but at the same time, the numbers are looking pretty good that the vaccine is doing what it's supposed to do.
In the interest of time, I see you, Dr. Singh, you had a quick follow-up to that, if you can make it. Okay, Dr. Burnett, there's a...
sorry, sorry. The professional oncology societies have come out in mass and advocated for patients with cancer actually to be prioritized to get the vaccine. So it's still an individual conversation, but there is agreement within the professional community that patients with cancer should be prioritized.
Thank you for that. Dr. Burnett, there's a lot of questions, several questions about some post-COVID symptoms, side effects, such as the loss of taste, the loss of smell. One of the questions specifically is, should someone see an ENT specialist to look at these symptoms? Or what is your recommendation about that loss of taste and loss of smell, the conversation someone should have with their provider?
So first of all, it's important to mention it, tell your doc that. Again, part of this process is we are all learning about that. So when we see patients, they see patients at UCLA in California, they see patients at Harvard on the East Coast. We're learning more about it. That's where that information comes from that I told you earlier, like these are the common symptoms. And, some scientists are starting to study, how does that happen and how do we treat that? So right now we do not have a specific treatment for that loss of smell, but it's important to count it, know how many people are having that, and then also what happens to that over time. Again, the vast majority of people with that symptom and many other symptoms is that it improves. So some people will say, oh, it's 80% better. I can smell a lot, but not as good as I used to. So, and we do expect it's going to get better. We can also, like Dr. Singh said, make sure there's not something else getting in your way, like a sinus infection. And then we will learn more about it and we will be able to treat people better in the long run. But most people will go on, over weeks to even months to get better with that. So seeing an ENT is not, unless it's getting worse or, really worrisome, they probably are not going to be able to do something for it, but at least seeing your primary care doc and getting in some system that can help you monitor it. And then, if it's taken a wrong turn, then you should go see your ENT.
Okay, and I'm going to put a quick plug in there for people to, one of the things we want to also utilize this panel in this space for is to remind people the importance of diversity in clinical trials. If you are battling COVID right now or in post-COVID and you get approached about participating in a clinical trial or a research study that may be monitoring your symptoms or just asking you certain questions, I'm going to highly encourage you to think about signing up for those trials, because the more people we have in the research studies that are answering questions about what they've experienced as related to COVID-19, the more in the scientific community, more data we'll have, and the more lives we'll be able to affect. So the next question is to any of you who, one of you feels comfortable answering it, is about pregnancy and the vaccine. Dr. Singh did mention that we know that pregnant women nor cancer patients were included in the early on clinical trials to test out the efficacy of the vaccine. So someone said, how many weeks, if they are pregnant, is there a particular time period when they should think about getting the vaccine? You want to jump in, Dr. Burnett, or someone?
Yeah, so as you mentioned, unfortunately, we don't have good data on that. We do not know of specific risks, or bad outcomes. So that at least itself is good. And generally that's being handled at the level of, individual conversations with your doc. If you have an OB-GYN doc you're seeing for your care, that's where that conversation is happening for the most part right now.
And Dr. Matthew, I'll pose this next question to you. Someone says, after, getting the vaccine, do they still need to get tested? And if so, how often?
Yeah, so there's no requirements that you need to be tested after you get the vaccine. So whoever that is, first of all, good job getting that vaccine, number one. And number two, there's no prescribed, schedule in testing. What I would encourage you to continue doing is, continue the other safety measures, the mask wearing and social distancing, all these other very important critical parts of protecting yourself, your family. But in regards to testing, additional testing, there's no CDC requirement or anything like that you need to be tested after getting the vaccine.
And Dr. Matthew, a follow-up question is that, have there been incidents where someone who's gotten the first dose of the vaccine or even the second dose of the vaccine and they've contracted COVID after getting the vaccine?
Yeah, so that's a good question, right? And, Dr. Burnett could talk a little bit about this too also, but it's all in the timing. I know, when I went to get my vaccine, one of the screening questions is, have you had any cold symptoms, so forth. that was going on within a certain recent period of time. So, there's always that possibility that, did you get it and you're asymptomatic, you somehow got the vaccine, and now you later on found to be positive. Remember, just to get the vaccine, it takes time for immunity to start build. It doesn't happen instantaneously. So there is a period of time, 4 or 5 days, where the immunity has to at least be primed in regards to being efficacious in your body. So while there is a slight chance possibility there could be overlap, it's very uncommon that, one of the big things I hear often is that, I got the flu shot and I got, COVID from it. That, has been challenged in the literature, and it has not really had any ground to be substance or have any legs to stand on in regards to the vaccine itself causing an individual to get COVID.
Thank you. And then just for those listeners who want to know, Dr. Singh mentioned, and both Dr. Matthew mentioned what the demographic looked like of who was included in the Moderna study and the Pfizer study. Now, I always encourage community members to know that that's public information. You can actually go to fda.gov and type in the search Moderna demographics or Pfizer demographics, and all that's public. And as a result, and this information, a lot of this is public, as a result of what we learned of a lot of the historical missteps that have happened. We have things in place such as the Institutional Review Board, the IRBs. We know how to monitor severe adverse events, which are side effects and things that may happen while someone is in a clinical trial. And one of the things that we have in place for emergency preparedness is this thing called EUA, Emergency Use Authorization. Our ability to make sure that we were able to develop this science in a rigorous way was not compromised as a result of the time we developed it. As scientists, we're very used to understand there may be times when we need to use what's called an EUA, Emergency Use Authorization. That does not mean that the rigor was compromised. And to that point, when I got both my doses of my vaccine, I was really, that question they asked me was about allergies. Dr. Burnett, someone in the chat has been asked a couple times to say, if I have an allergic reaction to vaccines in the past, or what are the two questions. One, if I've had an allergic reaction to vaccines in the past, what conversation should I be having with my provider? And two, are there specific allergies that should be considered prior to obtaining the COVID-19 vaccine?
Yeah, so that's a good question. And so talking about it with your doc or with the place that you're going to get a vaccine or thinking about getting a vaccine, letting them know, yeah, I had a bad reaction to whatever vaccine it was in the past. Now that does not mean, and it does not raise your risk of having a bad reaction to this vaccine. Those are two different things. But here's what happens. Number one, the most common side effects, these are not, we do not consider these allergic reactions. If you have, certainly aching of your arm or little flu chills the next day, especially after your second dose, that's normal, common side effects. Not everybody has that. The very, very small number, like less than 1 in a million, has a more severe reaction. So we do watch everybody, and that's usually quite rapid, like within a few minutes. Very rare though. We do watch everybody for at least 15 minutes. And if you've had any severe reactions in the past, we watch those people for half an hour. We have emergency equipment there just in case, but it's very rare.
Great. I'd love to jump in, if you don't mind. I'm sorry, Dr. Watson, at this moment. This has really been robust, and you've done an excellent job because I know there were plenty more questions, and our apologies.
We got most of them answered.
We did. But I know there's somebody out there who's saying, but they didn't ask mine.
It's true.
So forgive us. Time is a limitation that we have to respect. And that being said, I do want to thank all of the panelists. But before we conclude this particular session, which has really been robust, we also want to make sure to thank the Center for Information and Study on Clinical Research Participation. The two representatives who would like to address you before we conclude are Hope and Phyllis, and I hope that both Hope and Phyllis are on board to make their comments fairly quickly because we only have a couple of minutes left. Thank you, ladies.
Thank you, Rhea, and everybody. I'm Phyllis Kaplan, Senior Manager of Events and Communication here at CISCRP, which is the Center for Information and Study on Clinical Research Participation.
And I'm Hope Ventraselli. I'm the manager of events and community engagement. And we just wanted to let you know that our next event is happening on April 15th from 4:30 to 6 p.m. Aware for All is a free webinar and information exhibit center aimed to provide information about clinical research and health resources in your area. This virtual event includes free health exercises and informational discussions that feature community and research organizations, local physicians, and trial volunteers. And it also offers us the opportunity to thank those who have participated in research as our medical heroes. So to register for this free event, please visit awareforall.org.
Excellent. And I just want to remind everyone, I understand that the recording will be made available to those who would like to access it. I'm sure that information will go out to further explain that. Dr. Watson, exquisite. Dr. Burnett, thank you so much. Dr. Matthew, Dr. Singh, see you in the office whenever we get back there. But thank you for joining this particular panel. And now back to the ever exquisite Mrs. Phyllis Rogers, who brought us all together today for this important topic. Thank you.
Thank you. Thank you, guys. I mean, I just have a big applause. I know we're at the minute, and I'm just looking at the questions that have come through. Thank you, Dr. Watson, for so eloquently answering those questions. And I know some of them you answered within. So thank you so much, Rhea. Thank you for the opportunity to work with you again. And CISCRP, we want to put a big shout out to you for everything that you've done to make this project happen. And again, everything is being recorded. You will get that information so you can go back and listen, you know, at a later date. All we can say is that this is Black History Month, but it doesn't matter. It is what it is. And we are going to get through this. We're just asking everyone to please stay well. Please stay well. Do the best that you can. Continue to mask up, do all those things that we need to do, and just be well. And I thank everybody. And I would want to thank the people behind the scenes, Claudette and everybody on the Peer Plus team that helped me to pull this together. I want to thank everybody. And for those that could not get on, could not stay on, we thank you for the time that you did give us. Everybody, please be well.